graduated in mathematics. Sorry about that. He graduated in mathematics from the University of Siena. He earned his PhD from the University of L'Aquila and was visiting scholar at the University of Oxford. His interests concern the use of statistical models for the analysis of clinical data, multivariate methods for the analysis of longitudinal data, and machine learning techniques for diagnosis and clinical decision-making. So very much looking forward to your talk. And if that's okay with you, Professor, if you'd like to get going. I think you're muted.
You're definitely right. I still feel a bit unconfident with this stuff, but anyway, I'll try to do my best. First of all, I would like to thank all of you for being here. I would like to thank Professoressa Anna Teti for her kind, as usual, invitation, and Dottoressa Katie Desmond for her introduction as well. Today, I'll try to set up, to build up, if you prefer, a bit of categories of understanding tools to clarify what is meant when we talk about systematic reviews and meta-analysis. So I just keep on moving on my slides. So the first one refers to the problem of trying to characterize the knowledge. I mean that in many cases, we find in real life and in clinical practice mainly, there are many ways, many treatments, many performance habits that are not really tested and validated in rigorous scientific way. I just listed some of them just to be for being clever. For example, do we need to add a fluoride to drinking water to reduce the incidence of tooth decay in children? This is a common idea, and in many ways it's debated very much. So we found more than 200 studies of varying quality, and they have evaluated the addition, for example, of fluoride in the water, into the water we are used to drink. And but we find how could I say, discordant opinions. One example more, should corticosteroids be given in preterm infants? And here the same. Another very hot subject is, do we still have to recommend hormone replacement therapy to all post-menopausal women? And so on. Because we have evidence that there's a trial, but other ones, I just quoted one very important randomized clinical trials that indicated an increased risk of stroke. The body of evidence, what I would like to mean with this sentence. the main issue we face up when we are trying to document ourselves, reading literature, exploring the main scientific databases, is that we are how can I say, just a bit dismayed by the amount of indication of the information we face and we find in them. So the main issue is to try to get synthesis, to try to find how to adapt the information we find in the mainstream literature. This is the main focus, the goal that both systematic reviews and meta-analysis have. Meta-analysis and systematic reviews have date back to the late 70s of the preceding century, and surely has been a growing interest. What should be surely underlined is that behind the idea of RS and MA, systematic reviews and meta-analysis, there's a very common idea, and we could say an ideal of all of scientific thinking and of the scientific enterprise. They would like, would pretend to be continuous and cumulative. For example, since many years, the Medical Research Council for requests for funding of phase 3 and phase 4 studies has requested systematic reviews of the available studies in order to assess the relevance of the projects. Likewise, on the same line, if you like, the British Medical Journals requires a table that summarizes the knowledge on the subject matter, indicating what the new study adds and what is already known. Nowadays, according to David Sackett and many others authorities in this field, the development of the methodological clinical paradigm of the evidence-based, I'm sure you already heard about them, considers both systematic reviews and meta-analysis fundamentals in setting the guidelines for the clinical and medical area. According to the story I just sketched above, we can find along the history of mankind situations where procedures were not correctly documented. We have bleeding, bloodletting, the pneumothorax in physics, frontal lobotomy for psychic disorders. Remember that the daughter of Kennedy, of the President Kennedy, received a frontal lobotomy with not really amazing effects. Malarial infection from neurosyphilis routine supplementation of vitamin K, calcium, magnesium in pregnancy. And then are paired delays in the acceptance, even in the presence of evidence of efficacy. The most famous episode is surely the supplementation of vitamin C in the prevention of scurvy. It requested 40 years since the discovery. Hydration in cholera, thrombolytic therapy in heart attack, and so on. These are just few examples. The concept of evidence-based medicine, nursing, and generally speaking, knowledge is at the heart of the use and the implementation of systematic reviews and of meta-analyses. This pyramid is very important in defining the quality of the studies we are dealing with. And this feature is very important both in systematic reviews and in meta-analysis. We start very briefly from the bottom, what is usually called the so-called case studies, which enable us to provide hypotheses. We step up at the case control studies, group code studies, and so on, moving up the pyramid. The top of the single studies is considered, as you surely know, the so-called randomized control trials that are usually implemented in deciding about the efficacy and harmlessness of drugs. Two ingredients are fundamental when we select information. This feature is fundamental before starting both systematic reviews and meta-analysis, which can be considered the statistical counterpart of the systematic reviews. We have to investigate the studies in terms of both quantity, the magnitude of the studies, how many subjects in the single studies are present, and the quality. The quality is the aspect, in many ways, the most problematic side of the choice. The quality is linked very strictly, or can be defined somehow with reference with the pyramid of evidence I showed before. Just a very brief note, every year it is estimated that about 1 million articles are published in 30,000 scientific and popular journals, about 17,000 textbooks in the biomedical field. It's a huge amount of literature. Growth is estimated to be around 7% per year. The source is a socket. To let you taste the flavor of how physically works meta-analysis, I'll give some definitions I'll try to sketch some definition of a systematic reviews, which is very roughly speaking, the collection of information from the available literature, and the meta-analysis, that's the set of available statistical methods used to summarize the knowledge, having information about the magnitude of the effect of a treatment. Just to make my words more physical, you could feel the taste of our meta-analysis work. I would like to quote a very interesting example coming from Sir Ronald Fisher, one of the father of my subject, biostatistics. We have situations in which we have single correctly conducted studies, but with poor sample, not big enough, so that they may fail to demonstrate, to support a statistically significant relationship of their results, what is called usually as for a false negative. We conclude we have not statistically significant difference, and in fact we have a real effect. The idea comes from the fact that we have, if we have k independent tests, each study ended up with a statistical test and a p-value. A p-value is just the risk to accept the conclusion, and the conclusion is false. So in science, as you know, we have always to deal, to cope with the problem of accepting a risk to have a false statement. So we have as many p-values, as many estimation of the probability about a conclusion coming from the corresponding studies. It's a result of mathematical statistics that the quantity I indicated on the slide has a certain probabilistic distributions. I don't stop discussing the statistics. I just want to make clear the example. Suppose, for example, we have 5 different groups collect data to test the same hypothesis. So we have 5 studies regarding the same hypothesis, and all the studies have been correctly carried out. Each study reports the corresponding p-value if the result is statistically significant or it is not. And all the 5 studies we collected are not statistically significant. So we have 0.10, 0.06, 0.15, 0.08, and 0.07. None of these individual tests, as you can see, is statistically significant. The usual threshold in the biomedical sciences for statistical significance is the 5%, a p-value of 0.05. What, anyway, it's clear enough, looking at the p-values, is that they show a trend clearly close to the results statistically significant. Using the Fisher statistics, so that we summed up the p-values we have from the available studies, we get the value 24.3921. The probability of achieving a result larger or equal than this statistic is 0.0066. That's clearly statistically significant. It's lower than the significance threshold. So we have been able, using the Fisher method, to get evidence of our hypothesis, to corroborate, to support the hypothesis we hold, just summing up the p-values in this very, very smart way devised by Sir Ronald Fisher. Okay, this is a very interesting point, and it makes clear how much can be useful statistical treatment of scattered studies with different p-values. Now, I try to sketch two definitions. The systematic review is a review that has been planned according to an explicit and reproducible methodological path aimed at minimizing possible distortions, bias, and erroneous conclusions due to the loss of, I don't see what is written on it, or the introduction or of important studies conducted on a given topic. Meta-analysis, sketched before, is the statistical combination of data from independent studies undertaken to produce an overall estimate of the effect of an intervention exposure. What should be emphasized is that sometimes it is not appropriate to quantitatively combine information from studies that are too heterogeneous. What is common and I should say not clear enough is that systematic reviews not always has to be followed by a corresponding statistical treatment in terms of meta-analysis. If the heterogeneity among the studies is too high, this feature could be misleading, could let us believe that what we concluded, both in terms of statistical significance and about the magnitude of the overall effect, is wrong. The systematic reviews, unlike single studies, are studies whose quality, informativeness, and completeness are strictly defined by the information available in primary studies, as happens in the conduct of retrospective studies conditioned by the available information. What must be maintained is that systematic reviews are always retrospective in nature, and under this point of view, should be always based on an exhaustive and carried out on an exhaustive and detailed research protocol, so that the information carried by systematic reviews could be biased, could be affected by methodological problems, in the same way methodological problems can affect single studies. Here is a flow chart that I do not comment for time problems. Ethereugenity matters really much. It's the most important aspect of both systematic reviews and meta-analytical methods. We can try to categorize three main sources of ethereugenity we find in the meta-analyses. We have clinical ethereugenity. We have clinical ethereugenity if we consider jointly studies with differences in patients, treatment, exposure, study setting, and type of response. Outcomes, for example, measured with different scales. Methodological ethereugenity, this is very, very severe in terms of bias. We have methodological ethereugenity when studies are different in the design, in the conduct of the study, or in the analysis as well. So we can decide to use studies with different degrees of evidence. Okay, case control, for example, and cohort studies. It can be done, but it has to be treated with a lot of attention. And then last, statistical heterogeneity. One way to check for heterogeneity is to draw up a protocol with clear objective and with inclusion and exclusion criteria of the most restricted studies. This is the review, what I call the reviewer's question. What should be made clear is that what I observed is real or is biased. And despite bias is always lacking, the researcher, how much can be confident what he said is correct. There are many ways to select the sources of a systematic review. The traditional model is ask an experienced colleague, consult treatise, scientific journal, bibliography, and bibliographic research on famous and important databases. One issue I would like to mention is the so-called publication bias. Publication bias, very simply, the first who realized this problem, as far as I know, is Rosenthal in a very, very famous article, The File Drawer Problem and Tolerance for Null Results. He realized that the articles are affected by a differential error in the publication, are more likely to be published positive results instead of negative results. If I get a p-value to be very, very simple, less than 0.05, I have more chance that my article is going to be published. This is a very, very severe bias that's always affecting the selection problems of the studies when we plan to carry on systematic reviews and consequent meta-analysis. There are criteria. This is a possible list. I would like to avoid to emphasize too much this aspect, just for time reason. As expressed above, meta-analysis is mainly concerned, is devoted with the statistical treatment of a collection of studies in order to increase the statistical power and to get an overall estimation of the effect of a drug, of a treatment, of a protocol, and so on. Just few criteria to devise if the meta-analysis is appropriate. More than one study has estimated the effect of the treatment. The differences between studies do not allow a priori to hypothesize an impact on the outcome. The outcome in the various studies was measured in a similar or comparable, at least, way. The outcomes of the primary studies reported the numerical data that allow the combination. This is a very practical issue. In many situations, we haven't. And so we have to devise, if it's possible, for example, the standard deviation. We have the frequency of success, the mean effect, but we haven't the variance. We have meta-analysis is mainly a two-step process. We have an estimate of the treatment effect. Usually this treatment effect is calculating using odds ratios, relative risks, risk difference, in case the variable is continuous, of course. A second phase is the estimate of the overall treatment effect. And of course, this can be done in many ways. Sorry, I just copied what was above. The second one is the discussion of the possible bias affecting our estimation. Okay, I'm sorry. One important aspect is that the weights associated, weights in statistical terms, so it's a bit tricky to clarify this point, but not all the studies weights the same way. Of course, studies, for example, having a bigger sample size project on the final estimation of the overall effect this higher reliability due to the sample size. This is a forest plot. This is the form that we are used to find when we perform meta-analysis. As you can see, we have, for example, in this case, 4 studies. the subject was statin, and problems related to death and myocardial infarction. But it's not the subject of the discussion. It's not the clinical aspect, the medical aspect. So we have four studies. These weights are related to the sample size. For example, for the study PROVE-IT, it's 13% of the overall amount of subjects studied in all the studies I took into consideration. For each of them, I have the magnitude estimate and the associated p-value. And we end up summarizing the local results related to each study to an overall estimation of the effect using the 4 available studies, are in the same way we are used to manage statistical units when we perform single study analysis. And we see, for example, that the statistical significance is highly emphasized by combining these 4 studies. Well, we discussed the issue of statistics heterogeneity. We have two main types of heterogeneity in statistical terms that should be accounted for when we are performing meta-analysis. There's between inverted commas good, normal, acceptable variability, heterogeneity among studies due to chance. Just the chance decide if, for example, between 2 brothers, one is higher and one is shorter or is heavier, and so on. So this form of heterogeneity is intrinsic, is proper of any study. So this variability depends on the size of the studies. As you surely know, the bigger is the sample, the higher is the reliability of the study, because the heterogeneity shrinks. But sometimes, in many cases, and with a terrible form, very dangerous form in terms of the reliability of the results achieved, we have another kind of heterogeneity coming from methodological differences, as stated above. The latter type of heterogeneity generates an excess of heterogeneity compared to that expected. Thus, an heterogeneity that I expect, and that's the heterogeneity coming from chance. And this part of heterogeneity coming from variability among studies due to methodological difference or the ways they have been conducted can bias or final estimation. There are many ways to realize how much this problem of of heterogeneity, bad heterogeneity is affecting or analysis. There's what we could call an eyeball examination of a forest plot. This, for example, comes from the overlap between confidence interval. If I look at the previous, but also for example, this forest plot, we realize how much the confidence intervals are far apart. So in this analysis is severely affected by the bad heterogeneity. Okay, this is a very I'm sorry, I'm going back. Okay, and we have a more formal way to discuss if we are in presence of the bad heterogeneity. The heterogeneity not just due to chance. This is made up using statistics, the Q statistics. It's a very important statistics used in the meta-analytical studies. That's the weighted sum, weighted in the sense expressed before, of squared deviations between individual estimates and the pooled effect. Okay, and the relative degrees of freedom, but it's too statistical. These statistics enable us, if we are in presence or not of bad heterogeneity. This is a study. As you can see, there are many statistics reported below. This is the Q statistics, and this is the so-called E-squared Higgins statistics. That's a statistics that inform us, it gives us an indication of how big is the magnitude of this bad news. Okay, this is not a very good news. It's really bad, and it's really bad also, this indication. Okay, this is a study affected by bad heterogeneity. Okay, and this is the mathematical form of the so-called I-squared Higgins index. I do not comment, of course, the mathematical form. It relates to the Q statistics we mentioned before. But for example, if in a study it turned out that E squared is equal to 52%, this could be interpreted in this way. We have that more than half of the observed variability is not due to chance, but depends on possible differences between the methodological clinical studies. If the index is negative, but this is just a mathematical issue, by definition, it's set equal to 0. So, thank you very much, as written on, for your patience, your attention, and I hope I've been able to maybe not to clarify, but to set some curiosity in all of you.
Thank you very much. That was a very interesting talk. I'm sure everybody would agree. I'd just like to open it to the audience. If anybody has any questions or curiosities for the professor, please feel free to leave those in the chat now, and we can have a bit of a discussion before we finish today.
Of course.
Professor Tetti has her hand raised if you'd like
Yes,
to.
a moment. I'm trying. Oh, great. I've been able to be back on the normal screen. That's okay. Here I am.
Yeah, Francesco, yes, I'm very impressed by all these issues that come from analyzing a lot of data from literature, because being a senior scientist, I'm very concerned about the non-reproducibility of the data that is increasing a lot. So I would like to have your comment on that. And also, if you can comment on what is going on now, what is happening now with the clinical trials on the COVID vaccine, and that some of the scientists criticize because the number of patients is not that high. So what is your opinion, and how we can say something positive to the students here?
Sure. Your question, as usual, is very smart. I mean, the first part, it's easier, of course. The second is more controversial. I realized that in many occasions there's a lack, not of statistics, there's a lack of awareness of the problem. As you realized, maybe I emphasized the issue of Ethereugenity, which affects the issue of reliability, repeatability, of course. It's another face of the same coin, if you want, in a great deal of studies. And meta-analysis, it's a bad looking way to give an overall sorry, I got a very nice comment from a very nice woman now from my computer. That's right. Okay, we always appreciate it. It's okay. I'm sorry. It's a very big issue, and I think that this kind of awareness should be a main goal in terms of teaching activities, not just to teach statistics. I'm not interested in statistics, but to realize it's a serious, very, very serious problem. Just trying to answer your question, it's really hardly debated. At this moment, just a few days ago, I was talking to a friend at EMA in Amsterdam, and I have to say that I'm confident about the quality of the work they are carrying on. What I have to underline about, for example, the famous RT, okay, the factor of reproducibility that occurs in the mathematical model of diffusion. At the beginning, somebody said 60% of the population should be vaccinated. Later, 75%, 80%, and so on. I mean, this parameter, the herd immunity, can be rigorously estimated just in case RT is in a condition that mathematicians are used to say stationary. We have no changes, and we haven't this condition. We haven't. It's very dynamic, the situation. So actual immunity should be this, but this kind of statement is completely meaningless because we are in a dynamic situation. So you cannot talk about what we don't know and we cannot know. It's impossible in principle. It's a priori impossible. So, or you are honest and you say the number, but with all the amount of information surrounding it, or it's misleading your indication. It's surely going to be contradicted by the evolution.
I agree perfectly. Thank you.
Thank you. I have a question myself. Is there any particular area of science in your experience that applying this idea of systematic reviews and meta-analysis that is highlighted or produced a lot of insight? Is there an area of science you believe that it's produced a lot of, I don't know,
sure.
You know what I mean?
You're right. It's a very, very good question. I think that public health with of course selected topics, it's a very important area. And I think also oncology. Oncology, when we are talking about the evidence, clinical evidence of changes in the treatment effects. In this area it is widely employed. But I think that not just in the oncology field, it could be applied. In my personal experience oncology, surely, it's more debated in context, for example, of the neurosciences. It's more controversial, the application, but this is due not because it's useless, but because of the nature of the subjects you're interested in, you're studying. I mean, when you talk about psychology or psychiatry, you're dealing with, in philosophical terms, if you like, with fuzzy concepts. I'm not trying to diminish the value, to decrease the importance. What I realized in my experience is that usually important concepts are difficult to be defined. And the struggle is to find this. And I think that meta-analysis under this light could be employed very, very usefully. So in oncology, my answer is yes. It's already used, heavily used, and I think successfully used. In other area, it's like the area I mentioned. It's more controversial, a bit more problematic, but because of the nature of the subject, but it's important, maybe more because of it. So heterogeneity among studies, it's an indication in itself. You're talking differently about the same subject. And this is a precious scientific information.
Thank you very much. Yeah, that makes sense. I shall move to the chat. Sorry.
No, you're right.
I think we have another question in the chat from Ariana. She would like to know, how do you think students can start to use systematic reviews in their own work? Are there any introductory texts and or helpful software you could recommend to students?
Okay. This is very interesting. I'm afraid all the technical texts are a bit too technical to be folded alone. What is possible to find? There are good lectures giving more technical indications. For example, from the University of North Carolina, from Harvard as well. A very famous book, if you want a book, very well known and maybe used by the more skilled students. It could be the book of Hewitt. That could be used to be to carry on some, but it's always very technical, very heavy. It's not really easy to be read as a common book. I mean, with a sound background in biostatistics can be surely done. Okay.
Thank you very much. We can share that with the students. Are there any other questions for the chat before we finish the talk? I know we're nearing 2:30 now. Just give it a minute in case there's anybody else that would like to ask anything.
Sure. It's a very hard job, your job. Huh? It's really complex. I do not envy you now.
I think that must be everything. I'd like to thank you very much for the talk.
Well,
Incredibly useful.
I'm really happy and honored by your